Neurology quiz number 33. Discuss mechanism of action, uses, side effects, and dosing of zonisamide. Zonisamide is structurally related to sulfonamides and is a member of the methane sulfonamide group. It is FDA approved as adjunctive therapy for focal seizures, but is used as a broad-spectrum anti-seizure medication. In Europe, it is approved as monotherapy for focal and secondary generalized seizures. Zonisamide blocks T-type calcium channels, blocks sodium channels, and inhibits potassium-mediated glutamate release. It is an inhibitor of carbonic anhydrase, but much less potent than acetazolamide. It has excellent oral bioavailability, more than 90%. Protein binding is not significant. Tmax is 2 to 5 hours, and time to steady state is 10 to 15 days. It is metabolized by acetylation to form N-acetyl zonisamide and is also metabolized by reduction, mediated by CYP3A4. Metabolites are not pharmacologically active. In the absence of enzyme-inducing AEDs, half-life is 50 to 70 hours, while in the presence of such medications, half-life is 25 to 35 hours. Up to 65% of an administered dose is excreted as metabolites in the urine, and 35% is excreted unchanged in the urine. Phenobarbital, primidone, phenytoin, and carbamazepine can increase clearance of zonisamide and decrease its levels. Zonisamide can increase the levels of carbamazepine epoxide. It does not affect the metabolism of oral contraceptives. Common side effects include drowsiness, fatigue, ataxia, psychomotor slowing. Behavioral side effects include agitation, irritability, hyperactivity, and impaired attention. Paranoia, hallucinations, and psychosis may occur. Because of its cognitive side effects, it is not usually a first choice as initial monotherapy. GI side effects include anorexia, nausea, vomiting, and abdominal pain. Metabolic acidosis, decreased sweating, and hypothermia can be noted in children. Weight loss and skin rashes may occur. The drug may be associated with increased risk of kidney stones. Distal paresthesia may occur occasionally. Rare but serious side effects include Stevens-Johnson syndrome and blood dyscrasias such as agranulocytosis. Starting dose is 100 mg at bedtime for 2 weeks and then 200 mg at bedtime. The dose can be increased by 100 mg every 2 weeks as needed, up to 600 mg once at bedtime or in 2 divided doses. Therapeutic level ranges from 10 to 40 mg per liter. As the drug is renally excreted, dose may need to be lowered in renal failure. With creatinine clearance less than 20, its clearance is decreased by 35%. Zonisamide is substantially metabolized in the liver, and reduction in dose may be required with significant liver disease. Currently available evidence does not indicate that it has significant teratogenic potential. Its clearance may increase during pregnancy, requiring monitoring of levels and increase in dose. What is the mechanism of action, side effect profile, and dosing schedule for the recently approved drug Efgartigimod for myasthenia gravis? Efgartigimod is a neonatal fragment crystallizable receptor (FcRn) antagonist. The FcRn functions as a recycling mechanism to prevent degradation and extend half-life of IgG and albumin in the circulation. Its function is to salvage IgG and albumin from lysosomal degradation. It is expressed in muscle, skin, vascular endothelium, and serves a vital function in maintaining IgG levels. Other immunoglobulins such as IgM are not affected by FcRn recycling. Myasthenia gravis is an autoimmune neuromuscular junction disease in which IgG antibodies are directed against the nicotinic acetylcholine receptor or other components at the neuromuscular junction. FcRn antagonists are a novel approach for treating MG and other autoimmune diseases. Antagonism of FcRn increases IgG catabolism, leading to reduction in IgG and pathogenic antibody levels. In contrast to other immunosuppressive treatment, this does not result in widespread immunosuppression, as there would be no anticipated effects on IgA, IgM, IgE, complement, plasma cells, B cells, or other components of the immune system. Potential concerns would include reduction in serum albumin and IgG depletion, increasing risk of infection. An FcRn antagonist, Efgartigimod or vyvgart, was approved by the FDA for use in acetylcholine receptor antibody positive generalized MG in December 2021. This was based on data from the phase 3 ADAPT trial. The recommended dose is 10 milligrams per kilogram administered as an IV infusion over 1 hour, once weekly for 4 weeks on days 1, 8, 15, and 22. In patients weighing more than 120 kilograms, the dose is 1200 milligrams per infusion. Improvement has been observed within 1 to 2 weeks after the last dose. Subsequent doses are based on clinical evaluation. Safety of subsequent treatment cycles sooner than 50 days from the start of the previous cycle has not been established. Most common adverse reactions were headache, respiratory tract and urinary tract infection. Depression of WBC and lymphocyte counts was also noted. Majority of infections and lab abnormalities were mild to moderate in severity. Patients should be monitored for signs and symptoms of infection, and in patients with an active infection, the medication should be stopped until the infection has resolved. Hypersensitivity reactions including rash, angioedema, and dyspnea were observed in some patients. These were mild to moderate and occurred within 1 hour to 3 weeks of administration and did not lead to treatment discontinuation. As efgartigimod can decrease IgG levels, immunization with live vaccines is not recommended during treatment. Patients should be evaluated for the need to administer age-appropriate vaccines according to immunization guidelines before initiating a new treatment cycle. This agent shows promise in management of myasthenia gravis given the drawbacks of current rapidly acting treatments such as IVIG and plasma exchange, which include availability, cost, duration of treatment, need for specialized access, side effects, etc. The significance of a transient lowering of IgG levels in patients who are also on oral immunosuppressive medication will require more long-term data.